Welcome back. My name is Michelle Weckman, and I'm a physician at the University of Iowa with expertise in family medicine, psychiatry, and hospice and palliative medicine. In this part of the training program, we're going to review some of the legal definitions and the concept of decision-making when it is shared between the patient, family, and healthcare provider. The case example of Mrs. Klein will be used to illustrate key points. Goals of care are critical to providing the care which is desirable to a patient and family. Determining goals can be difficult because they may change over time and can be hard to elicit from a patient with dementia. It is very helpful to interview the family and friends to understand what the patient was like before the dementia started. This would include asking about things such as hobbies, life goals, styles of interacting, and previous health decisions, such as the use of herbal remedies, willingness to seek and accept medical care when ill, and the willingness to take medications or treat medical illnesses. The more you understand about a dementia patient's previous choices and wishes, the better you can ensure that future treatment is in line with what the patient would have wanted. When talking with the patient and family about possible treatment or treatment options, it is important to understand the concept of informed consent. Informed consent occurs when someone understands both the treatment options and the consequences of choosing a specific treatment. Additionally, the person needs to be able to make and communicate a decision. The capacity to make a decision can change over time and needs to be reevaluated continually. A person can also have the capacity to make one type of decision but not another. For example, when Mrs. Klein's dementia was mild, she was able to understand that she had a bladder infection and weigh the risks and benefits of taking antibiotics. However, she was not able to understand why she needed to be placed in a nursing home. Her family needed to make the decision for placement. In general, as a person's cognition becomes more impaired, their ability to give informed consent decreases. When a patient is no longer able to understand the question being asked and make a well-thought-out and logical decision about treatment, we turn to a surrogate decision maker. Typically, this is a close family member. Sometimes a patient has filled out a healthcare durable power of attorney form, and in those cases the person listed is the legal decision maker, even if it is not the closest family member. A physician cannot be designated as a healthcare power of attorney for a patient. When we talk with surrogate decision makers, we ask that they make a decision based on what the patient would have decided, not on what they think is best for the patient. In the example of Mrs. Klein, once her dementia had progressed to the point she was unable to make decisions, her husband was asked to make decisions for her. When she developed a urinary tract infection, we asked her husband what was important to Mrs. Klein and what her previously stated goals were. Her husband told us that she saw her parents in a nursing home and never wanted to go to one herself unless it would help her family. She adored her children and said more than once that as long as she knew her husband and her children, that life was worth living. She didn't like taking medication, but was always willing to see the doctor and take medications for treatable conditions such as infections. Based on his explanation, we agree with Mr. Klein that his wife would have wanted treatment for her infection as long as her dementia was not so severe that she did not recognize her family. So, as a physician, how much information are you required to tell a patient or surrogate decision maker? Legally, you need to explain the suspected or diagnosed condition, recommend evaluations and treatments, and make sure the patient or surrogate decision maker understands what you have said. Of course, we need to use our best judgment when giving information. You should always determine how much a patient or surrogate decision maker wants to know and allow them to designate someone else to receive the information if requested. We are no longer allowed to hide information because we, or someone else, believes it is in the patient's best interest not to know. For example, suppose Mrs. Klein's daughter came to see you and was concerned that her father was too stressed. She requested that all information about her mother be given to her and said that she would tell her father what he needed to know. You agreed that Mr. Klein seemed more stressed lately and thought it might help him to have a break from hearing all the details of his wife's condition. However, you need to ask Mr. Klein specifically if he wants you to start giving information to his daughter first, allowing her to communicate it to him. Currently, shared decision-making is considered the gold standard for making decisions about treatment and management of medical conditions. In this model, both the decision maker and the healthcare provider discuss the decision in light of the patient's goals. This type of discussion can be time-consuming, but it has been shown to improve healthcare outcomes. Shared decision-making has been shown to improve patient and family satisfaction with care, prevent medical disputes, and increase treatment effectiveness through better compliance, since the patient feels invested. Additionally, shared decision-making may decrease healthcare costs by ensuring that the care given is in line with what is appropriate and what a patient wants. Shared decision-making is a dialogue, not a stream of one-way communication. This makes it more time-consuming. It is important to allow the patient to have control and empower the patient to express preferences and make decisions. It starts with eliciting the patient's past and future goals and using those to customize how much information is given and what treatments are offered. For example, suppose you have a patient whose dementia has progressed to the point that he rarely recognized family and often chose not to interact with them when they did visit. He has been losing weight, has abdominal pain and blood in his stool, leading you to suspect that he has colon cancer. He has a very detailed living will, which says that he does not want any further life-prolonging treatment once his dementia progresses to the point that he is unable to recognize family and friends. Given the severity of his dementia and his clearly stated goals, you might choose to tell the family your concerns while recommending a comfort-oriented approach. This would honor his living will. However, if his dementia were still mild to moderate and he clearly knew and enjoyed visits from his family, you might recommend doing a more thorough evaluation of the abdominal mass, with the idea of possible treatment with a goal of cure or life extension. Not all patients or surrogate decision makers want to engage in shared decision making. Some, particularly elderly patients, may simply request that you do what you think is best. In those cases, it is still helpful to elicit the patient's goals and values so that you can offer a treatment plan which is consistent with those values. We will use antipsychotic initiation to demonstrate shared decision-making. We have developed a fact sheet for antipsychotic use for family members, which is designed to facilitate shared decision-making. As you can see, the guide was written using user-friendly print and text and was designed as a tool that you can use to walk a decision-maker through the process of starting an antipsychotic. The fact sheet defines dementia, antipsychotics, and appropriate and inappropriate treatment targets. It also talks about the possible benefits and side effects and discusses which side effects you should watch for and how to monitor for them. Pertinent to shared decision-making, the family handout gives tips designed to help the family decide about accepting the use of an antipsychotic and how to make that choice. Getting back to Mrs. Klein, her dementia worsens. Over time, her paranoia about food persisted, and she continued to lose weight. Despite an initial good response to the non-drug interactions targeted at her jealousy and concerns about her husband, she also eventually developed jealous delusions that he was spending time with another resident. This led to verbal outbursts directed at the other resident and much distress from Mrs. Klein. Because of these apparent delusions and their consequences, it was decided that the possibility of using an antipsychotic should be discussed with her husband. You are prepared to offer an antipsychotic trial and provide the family with the copy of the antipsychotic family handout. There are appropriate and inappropriate behaviors to target with antipsychotics, as seen on the Antipsychotic Prescribing Guide and Family Antipsychotic Handout. As you can see on the Antipsychotic Prescribing Guide, behaviors which do not cause extreme distress to the patient and are not dangerous to the patient or others are not appropriate reasons to initiate an antipsychotic trial. This often needs to be explained to care centers and families who are distressed by some of the behaviors typical dementia, such as wandering and calling out. In order to ensure informed consent, you need to fully discuss the risks and benefits of antipsychotics. It is helpful to know what the patient and family goals are for the treatment and to explore what tolerance they would have for side effects. In some cases, the family's goals may be unrealistic. For example, they may want the medication to not only stop the behaviors, but to also improve cognition and enable their loved one to function better. It can also be helpful to ask the family why they think the patient is having the specific behaviors. Families can often provide clues to why a behavior is occurring, which may trigger a non-drug treatment strategy, or it may provide an opportunity to provide further dementia education. The issues that prompted consideration of an antipsychotic for Mrs. Klein are related to delusions. When these issues were milder, they responded well to non-drug approaches. but they've worsened over time and non-drug approaches are no longer effective. Upon talking with Mrs. Klein's family, you learn that the behaviors are very distressing. They clearly say that she would never have acted this way and that she would be mortified if she knew what she was doing. In addition, they are very concerned about her refusal of food and weight loss. If her dementia was more advanced, the decision might be different. But she is still able to recognize her family and enjoys their visits. They are willing to accept the risks of side effects with antipsychotics and believe that Mrs. Klein would have chosen to take an antipsychotic if she could have seen her current condition when she was cognitively intact. They also feel that she has been comfortable and well cared for in the nursing home and do not want her transferred to a dementia unit for further treatment and evaluation. After reviewing the antipsychotic handout, the family decides to try antipsychotics. When initiating an antipsychotic, it is important to discuss the potential risks and benefits. In Mrs. Klein's case, the benefit would be decreased delusions and aggressive behaviors and her continued ability to remain in her current placement. Antipsychotics have clear side effects, which are described in detail in the Antipsychotic Selection mini-lecture and can be seen on the Antipsychotic Prescribing Guide. Specifically, antipsychotics have specific side effects based in part on their receptor affinity. At the least, it is important to mention that there is a slight increase in the risk for death when dementia patients take antipsychotics. Also, be sure to mention any common side effects, such as the potential for movement side effects with haloperidol or the potential for weight gain and sedation with olanzapine. All medications can cause adverse effects. Some of these can be mitigated with early recognition and treatment. More detail can be found in the mini-lecture on antipsychotic monitoring. Briefly, by looking at the table which shows specific side effects for the different antipsychotics, you can determine which side effects you need to monitor for with each antipsychotic. Once you know which side effects are the most common, the monitoring table will give specific suggestions for ways to monitor for the side effects you are most concerned about. These monitoring ideas can then be shared with the nursing home staff or home caregivers. The antipsychotic family handout has a convenient form on the back listing the most common side effects and can be given to family. Monitoring for antipsychotic side effects empowers a family to be able to continue participating in shared decision-making and to help determine when or if side effects are severe enough to prompt treatment discontinuation. Facilitated decision-making occurs when a provider and patient, or surrogate decision-maker, make decisions about care jointly. In order to engage in shared decision-making, each party must contribute to the discussion. The provider must contribute the medical facts, and the decision-maker must contribute the goals of care, filling in details about the patient's likes, dislikes, and previously expressed wishes. When shared decision-making occurs, both the decision-maker and the provider report increased satisfaction with care and improved outcomes. The backbone of shared decision-making is having a good understanding of the patient and family goals for care. Sometimes patients and families can't readily express their goals. In those cases, you need to explore likes, wishes, and previous choices to come up with a goal that they can accept. It can be difficult to honor goals which you do not support. For example, you believe a patient with end-stage dementia is suffering and has a prognosis of less than 6 months, and you have recommended hospice support. However, the family are not ready to let go and repeatedly request transfer to the hospital for evaluation and treatment every time their dad has a change in condition. In this case, frequent, honest, and compassionate communication, explaining the medical facts and prognosis while exploring family fears, desires, and hopes can help to bring about an alliance of goals. Sometimes these situations can be avoided by talking early in the dementia process about the natural progression of dementia and informing a surrogate decision maker about common decisions which need to be made as the dementia worsens. Thank you for taking the time to view this mini lecture on shared decision making. We hope that it was informative and will be beneficial. Please take some time to view our other mini lectures designed to guide evidence-based use of antipsychotics in patients with dementia. Have a great day.